All right, so this is going to talk about mood disorders, which includes depression and bipolar, and also suicide and suicidality. So the big things that we're going to talk about with mood disorders are going to be depression, some mania that goes along with bipolar, and suicidality. So for depression, we have a couple of different types of depression. We have major depressive disorder, which is MDD, seasonal affective disorder, which is SAD, persistent depressive disorder, premenstrual dysphoric disorder, PMDD, and substance-induced depressive disorder. So for SADS, I'm going to start with that one because it's the easiest. It's a form of depression that typically occurs seasonally, hence why it's called seasonal depressive disorder, affective disorder. We have this typically occurs during the winter time when there is less sunlight. It's thought to be caused by a lack of sunlight, which is why photolight therapy is the first line of treatment. This can also happen year round for some people, especially those like who live in Alaska where it's dark almost all the time. In Washington State where it's cloudy and there's minimal sunlight, you may see that as well. So this is something, while it is typically seasonal, anybody who's not getting enough sunlight can experience this. Our major depressive disorder is an episode or recurrent episodes of depression that's not associated with mood swings or mania, which we already which we'll talk about here in a little bit. This is going to change the way that somebody is functioning, and some of the side effects or manifestations that you'll see include a depressed mood, difficulty sleeping or excessive sleeping, indecisiveness, decreased ability to concentrate, suicidal ideation, increased or decrease in motor activity, inability to feel pleasure, which is that anhedonia, increase or decrease in weight. And these can be coexistent with psychotic features, so major depressive disorder with psychotic features. And this is where hallucinations are also present. We also have postpartum depression as another subcategory of major depression, which can occur 4 weeks after childbirth. And this can include delusions, which can put the newborn at risk for being harmed by the mother. So we got to be mindful of that. That's why we screen for that at postpartum visits. We have persistent depressive disorder, used to be a dysrhythmic disorder. It's a milder form of depression, usually seen in children or adolescents. And this disorder contains at least 3 clinical findings, where major depression contains 5. But typically this persistent depressive disorder will migrate into major depressive disorder later in life. We have the premenstrual dysphoric disorder, PMDD. That's the depressive disorder associated with menstrual cycle. And then we have substance use or substance-induced depressive disorder, which is just like what it sounds. That is our depressive findings, but it's caused by the use of or the withdrawal from alcohol. Some things to also note is that Alzheimer's disease as well as traumatic brain injuries can induce depression. And hypothyroidism can also cause manifestations of depression. So those are things we need to look at. Just like with psychosis, we have to look at medical first. So for MDD, there's typically 3 phases. There's the acute phase. This is when the severe clinical problems happen and we start treatment. This usually lasts 6 to 12 weeks. and they may need hospitalization, especially if suicidality is present. Our goal is to reduce the depressive manifestations and keep them safe from harming themselves. During the continuation phase, we're going to have an increased ability to function. This is usually 4 to 9 months. And our goal is relapse prevention through education, medication, and therapy. Then we have the maintenance phase, which is where we have remission from our manifestations. This can last for years, and our goal is to prevent a future depressive episode and maintain our treatment. We have risk factors for depression is, of course, a family history or a personal history of depression. Being female, it is more common in females, but it does occur in males. It's very common amongst the elderly, the geriatric population, which we'll talk about a little more when we get to that section later in the semester. We have neurotransmitter deficiencies, typically thought to be a lack of serotonin. That lack of serotonin, so that's why we use our SSRIs and our SNRIs to increase that serotonin. We have other factors that can include stressful life events, trauma that occurs early in life, medical problems, especially chronic medical problems, postpartum, and then anxiety, personality disorder, or substance use disorder usually kind of go hand in hand with depression. So some terms that we may see along with our expected findings, that anergia, which is that lack of energy, anhedonia, which is that lack of pleasure, anxiety, sluggishness, like you can't relax, just kind of feeling fatigued and slow, change in eating patterns, maybe have some constipation and sleep disturbances. We'll typically have a decreased interest in sexual activity, so that decreased libido. We may have somatic issues like fatigue, GI pain, things like that, constipation. So these are true problems, but they're because of the depression, not because of a medical problem. Some physical assessments, maybe that blunted affect. They're going to be poorly kept, so poor grooming, no hygiene, dirty clothes. We'll see that psychomotor retardation, which is that slow movement. Or we can also have psychomotor agitation, where they're restless, pacing, tapping, things like that. We can see a lot of social isolation and slowed speech as well. Things we need to be mindful of is our milieu therapy. We have to maintain a suicide risk assessment and assess their risk for suicide daily and implement safety precautions, whether it be one-on-one, frequent checks, things like that. We're going to monitor their ability for ADLs and independence, and we're going to use communication, especially in those who are unwilling or unable to communicate. We're going to try that therapeutic communication with body language, silence, things like that. So our treatments, pharmacologically, is our SSRIs, SNRIs, TCAs, atypical antidepressants, and St. John's wort. For all antidepressants, we do not want to discontinue suddenly. We want to know that the effects are not immediate. We want to avoid hazardous activities and notify the provider of any thoughts of suicide. We also want to always avoid alcohol. So that being said, I also need you guys to think back to pharmacology, because this stuff doesn't leave us, and think about some of the things like serotonin syndrome, the side effects from SSRIs like weight gain, sexual dysfunction, our orthostatic hypotension from TCAs, those things. We got to keep remembering those things because they don't go away. We also have our CBT, which is that cognitive behavioral therapy. This helps the client think differently, so it's kind of that reframing. Light therapy, like we said, it inhibits nocturnal secretion of melatonin. So our goal is to pretty much set them in front of a light and help their body produce what they need to produce. So then we have our ECTs, which is electroconvulsive therapy. So with this medication or this treatment, we are intentionally inducing a seizure. Now, this is not done like how you see in the movies as a method of torture. This is done by sedating the client, putting them out, inducing the seizure, and then waking them back up. So that being said, a lot of our complications that come from this includes memory loss and confusion, especially short-term memory loss, some disorientation, especially right after this procedure and for several hours after, retrograde amnesia, which is that loss of memory to the things that happened before the procedure. So I know that safety is important, but we have also talked about Maslow applies to our psych patients too. When our client has ECT, our priority is their airway because they've just been sedated. So we need to kind of remember that. Okay. We need to make sure we're continuously monitoring them, monitoring that airway, making sure we prevent injury, provide a safe environment, frequent reorientation. We want to monitor for cardiovascular issues, reactions to anesthesia like that malignant hyperthermia, things like that. Some of our education is going to note that ECT is not permanent and they will require maintenance ECT so that we don't have relapse. So that's your big things for ECT is your post-op instructions, your post-op nursing care, things like that. TMS is transcranial magnetic stimulation. This is non-invasive. It uses magnetic pulsations from an MRI machine that stimulates the cerebral cortex of the brain. So essentially you just sit there and a machine goes with a magnet runs around your head and helps stimulate that cortex. So we want to educate our client. It's typically prescribed daily for 4 to 6 weeks and is typically performed outpatient and will last about 30 to 40 minutes. It is non-invasive. They may feel tapping or knocking as the magnetic field goes around them, but that is normal and unharmful. We can have that mild discomfort or tingling at the site of the electromagnet and headaches. We can have lightheadedness after the seizure or after the procedure, and seizures are rare but can happen. There's no real systemic adverse effects, but it is contraindicated in those who have cochlear implants, brain stimulators, or medication pumps because of the metal inside of the procedure. So basically, the magnet and the metal inside of the device. So basically, anybody who cannot get an MRI is contraindicated for this treatment because of the magnet. We have vagus nerve stimulation, which is VNS. This was used to treat seizures, but they also found benefit of it with our depressive patients, so they started using it. Basically, it is a device that's put onto the vagus nerve under the skin in the chest, to kind of like a pacemaker, and it delivers neurotransmitters and electrical impulses to the brain to help mimic the same actions of antidepressant medications. This is typically an outpatient surgical procedure. It's going to deliver around-the-clock pulsations. And you can turn it off at any time by using a special external magnet. We will have to get consent, though, because this is a sedated procedure. Because of how close the VNS is, the vagus nerve is to the voice box, to your larynx and pharynx, you may have some voice changes, which is normal. And this can cause hoarseness, coughing, things like that. And these typically go away over time. So suicide is the intentional act of killing oneself. We have, there's a lot of myths that go around suicide. The first one is that people who talk about suicide never commit it. Yes, they do. They will. And it needs to be taken seriously. People who are suicidal only want to hurt themselves, not others. That is not true. Suicidal thoughts can be triggered in a revengeful manner. There is no way to help someone who really wants to kill themselves. Yes, there is. We have treatment for that, but we have to get them the treatment that they need and help them get those coping skills in. This is a big one that a lot of my new grad nurses had a hard time with on the psych floor. Asking a client about suicide, what will cause them to become suicidal. That is not true. The best thing that you can do to assess suicidality is ask, are you suicidal? And then you have to kind of go into the plan and all that safety part, which we'll talk about here in a minute. Another big one is ignoring verbal threats of suicide or challenging a person to carry out suicide plans will reduce the behaviors. This is not true. This will actually induce the risk of suicide and enhance the risk of suicide. And people who talk about suicide are only trying to get attention. That is absolutely untrue. So things to think about: while females are more likely to attempt suicide, it does happen in males. Other people at risk are going to be our active military and veterans, those of the LGBTQIA community, people who have other comorbidity, mental illnesses such as depression, substance use, schizophrenia, bipolar personality disorder, anything like that. Our biological factors include a family history of suicide, physical disorders, any kind of chronic medical condition, especially one that impacts your quality of life. We have psychosocial factors such as senses of hopelessness, intense emotions of rage, anger, and guilt, poor interpersonal relationships, and our adverse childhood experiences, those ACEs, and a history of trauma and abuse. We also have our environmental factors, such as an access to lethal methods like firearms and a lack of access to mental health care. We have protective factors, such as feeling responsibility towards people, pets, partners, children, a current pregnancy, religious beliefs, satisfaction with life, social supports, positive coping, and access to medical and mental health care. So let's talk about a suicide attempt versus suicide ideation. Suicidal ideations is the thought of wanting to end your life. Suicide attempt is the act of trying to do something to yourself to end your life. And a suicide, a completed suicide, is one where that was death was achieved. So we do have some warning factors that come about with suicide. And this is clients stating that they want to die or kill themselves, or stating that they feel hopeless, empty, have no reason to live. They feel trapped. They are in physical and emotional pain, saying that they're a burden to others. Withdrawing socially, a big indicator is giving away possessions. Saying goodbye to friends and family, arranging affairs, engaging in risky behaviors, and obsessively thinking about death. Other ones may be having a sudden or extreme mood swing, developing a suicide plan. This can happen by things like collecting pills to overdose on, buying a gun, things like that. Complaining about guilt or shame, increased use of drugs or alcohol, being anxious or agitated, change in sleeping habits, rage, or talking about seeking revenge. We're going to want to assess carefully for verbal and nonverbal cues, like we just talked about. And as we talked about, it's essential to ask the client if they are thinking about suicide. This will not cause them to commit suicide. These suicidal comments are usually going to be made to someone that the client perceives as supportive. These can be overt, which are direct. This is, I want to die. Or it can I just want it to be over. We have covert symptoms, which is undercover. Everything's looking pretty rough for me. Kind of just talking more casually about it. So when we ask if someone is suicidal and they say yes, we need to delve more deeper. We are going to want to assess the plan. Do they have a plan? Is the plan lethal? Can they describe how they're going to work out their plan? Do they have access to perform this method they have thought of? Is there a mood change? And a big thing for that is a sudden change in mood from sad to happy can indicate an intention on suicide. So if one day they were depressed, crying, sad, awful, and the next day they're happy, ready to go home, they're ready for discharge, that should be a big red flag for you. And then we can also see some physical symptoms such as lacerations, scratches, scars, with indications of wanting to self-harm. A big one that I've seen is ligature marks around the neck and busted blood vessels within the eyes. After discharge, our goal, we want our patient to be able to agree to a no suicide contract, or contract for safety. This is a verbal or written agreement to not harm themselves and seek help. This is, of course, not legally binding, and it can be beneficial, but it doesn't replace other strategies to help the clients. It can be used as a tool to develop and maintain trust with the client and the nurse, but it is discouraged for clients who are actively in a crisis or under the influence or very impulsive. So when we're caring for them, for clients with suicidality, we have primary, secondary, and tertiary, just like always. Primary interventions focus on prevention through the use of community educations. Secondary is going to be screening clients who are in an acute crisis and initiating suicide precautions. And tertiary is going to be providing support and assistance to the loved ones of somebody who has completed suicide. So lastly, we're going to talk about the 3 types of bipolar. These are going to be mood disorders with reoccurrent episodes of depression, which we already talked about, and mania. So typically we are going to have periods of functioning that alternate with periods of illness, and some people will not be able to function at all. A lot of times we can exhibit psychotic, paranoid, and bizarre behavior during mania. So that's something to think about. During our acute phase of mania, hospitalization can be required, and they could be a risk to themselves or others due to the impulse control. So we'll kind of talk about that in a minute. So we have our bipolar 1 disorder, which is going to be one episode of mania that alternates with depression. We're going to have bipolar 2, which is hypomanic episodes that alternate with depressive episodes. And cyclothymic disorder, which is at least 2 years of repeated hypomania that don't quite meet bipolar 2. So during mania, this is a abnormally elevated mood that can be expansive or irritable and can require hospitalization. Some findings are going to be that libel mood with euphoria, agitation, irritability, restlessness, dislike of interference, so they can get really angry at you when you try to stop them from doing things. Increased talking and activity, some of those psychotic and delusional things like flight of ideas, topic changing, grandiose views of self, impulsivity. This could be spending money, gambling, using drugs, things like that. Decreased attention span, poor judgment, and attention-seeking behaviors. We're going to have impairments within social functioning. We're going to have decreased sleep. Manic people do not sleep. And then they're typically going to neglect their ADLs that include nutrition and hydration. So remember Maslow's: sleep, nutrition, and hydration. These are important factors. Hypomania is going to be less severe mania that lasts about 4 days and has 3 or 4 manifestations of mania. Typically with hypomania, hospitalization is not required because hypomania is less impairing, but hypomania can progress to mania if left untreated. And then we also have what's called rapid cycling, which is 4 or more episodes of hypomania or mania within a year. Okay. So that's when we have our mania. This is going to be a switch between mania, and then we could turn into depressive characteristics, which are going to be just like our major depressive disorder, things like that. Flat, blunted affect, tearfulness, crying, that lack of energy, the lack of pleasure, lack of sexual activity or sexual desire, physical pain, those somatic problems, difficulty concentrating, self-destructive behavior such as suicidal ideation, decreased personal hygiene, loss in appetite. So all those things that we see in depression are going to happen during the depressive stages of bipolar. So maintaining safety and physical health and maintaining their self-needs. We need to maintain a therapeutic milieu and maintain a safe environment during our acute mania. We want to assess regularly for suicidal thought, intention, or escalating behavior. And we want to decrease stimulation without isolating the client. We want to make sure we're aware of any kind of noises in other clients that can stimulate the client with mania. Of course, we're going to follow facility protocols for protection, such as restraint, seclusion, and 101. And if a threat or injury to others or self exists. We want to implement frequent rest periods and provide outlets for activity. We do not want to involve the client in activities that last a long time or that require a lot of concentrating because they don't have that ability right now. And we want to protect the client from poor judgment, impulsive decisions, and things like that. We want to make sure that we maintain their self-care needs, such as sleep, fluid intake, nutrition. We want to provide that portable, nutritious meal because they may not be able to sit down. This is where like our protein bars, our protein shakes, our hamburgers, things like that come in handy. So some complications. Remember what I said. Manic people don't sleep. Sometimes they're not eating or drinking. This can lead to a state of physical exhaustion, which can lead to death and become a medical emergency with the dehydration. When we communicate with our clients with bipolar, we want to make sure that we are using calm, matter-of-fact approaches, giving concise explanations. We want to provide consistency and limit setting. We do not want a power struggle. We want to listen and act on client grievances when they're legitimate and reinforce non-manipulative behaviors. Some of our treatment, especially in that is going to include mood stabilizers such as lithium and anticonvulsants. You need to remember these from pharm. Remember your lithium toxicity. Remember what lithium does to sodium. Your anticonvulsants, remember a lot of them hit the liver and the CBCs, so we need to monitor that. We can also use antipsychotics for our acute mania and antidepressants for our depressive episodes. We can also use ECT when lithium does not work. And our biggest thing is to prevent them from harm, make sure they have fluid intake, make sure that they're sleeping, and that their medication is being taken and managed appropriately.